My name is Dr. John Roesler. I'm a board-certified otolaryngologist, and with an interest in sleep and sleep apnea. I am trained at UCLA in the Division of Head and Neck Surgery. I'm an assistant clinical professor there.
How can an otolaryngologist help for the patient to breathe better and to be able to use oral appliances or CPAP better?
As an otolaryngologist, what we do is evaluate the ear, nose, and throat, upper airway, which includes breathing through the nose and being able to breathe well through the oropharynx, which is particularly an issue sometimes for patients with obstructive sleep apnea at night. In terms of evaluating the nose, it's very important for patients who are going to be using CPAP or a dental oral appliance that they should be able to breathe well through their nose.
Why is it so important to be able to breathe through your nose?
It's really important to be able to breathe through your nose because the nose has the unique ability to heat, humidify, and filter air in a manner that's comfortable, as opposed to breathing through your mouth, which results in dry mouth and discomfort. It is more comfortable when we're vocalizing to be able to vocalize through the mouth but take in the air through the nose. There's a natural physiologic mechanism that makes it easier to do that with breathing through the nose. Same thing with eating. When we eat, we can chew, keep our mouth closed, swallow, but all while intermittently breathing through the nose.
Okay, and breathing through the nose is critical for CPAP use, correct?
That is correct.
So let's say somebody has a problem with breathing through their nose and they're given CPAP. What sort of process do you go through to help them to use a CPAP?
Well, what I like to do first is just ask the patient about their breathing. Things that I get into with the patient and ask them about include whether they've always had trouble breathing through their nose, whether one side is better than the other, whether they have allergies or non-allergic congestion, whether they have a history of sinusitis or a history of nasal polyposis. Also different factors that might influence what time of day they have trouble breathing, whether they have trouble breathing at night versus during the day, which I think can be suggestive of sometimes of like a dust mite allergy that might occur when they get in bed, although also it could just be a positional issue. And then we can start talking about the nasal examination.
Okay, so let's say it is somebody that has trouble breathing through their nose at night, which is when when they're going to bed, which is when they're going to be using their CPAP. What are the things that they can do, the simple remedies that they can do to enable breathing better through their nose? Do they sit up more reclined? They sit up straighter versus reclined? Do they have a humidifier in the room? Mm-hmm. Do they get rid of all the carpet and down comforters and all those things?
Mm-hmm. When we're looking at difficulty breathing at night, again, one of the things that I like to explore, if that's a specific issue, that is breathing difficulty through the nose at night, I like to look at whether the patient might have a dust mite allergy. We can do a simple blood test called the immunocap test, which will reveal if someone does have a dust mite allergy. So that's sort of one of the first things that I explore. If that testing comes back positive or suggestive, then we could try different medical therapies to treat that allergy. So we can try a nasal steroid spray or a nasal antihistamine spray or an oral antihistamine to treat that allergy and see if we can improve the breathing through that modality.
If it's unilateral problem, so they have trouble breathing through their nose, but it seems to be one-sided, is that suggestive of something else?
I think that tends to be suggestive of an anatomical obstruction. For example, a severely deviated septum which may occur either in the context of a prior nasal injury or maybe something that they inherited. So certainly severely deviated septum can cause major obstruction on just one side of the nose, although the other side may be obstructed as well because the turbinate, which is the structure in the nose which allows the nose to heat, humidify, and filter the air, may compensatorily enlarge.
When people use Afrin, like on a temporary basis, like for 1 to 3 days, and they get a remarkable response, they're encouraged to use it more, and yet we know that's not productive after that period of time. Can you talk about how Afrin can be helpful both as a diagnostic test and why it's not helpful beyond that?
Afrin is a nasal decongestant, so it's a vasoconstrictor. It squeezes all the blood out of the turbinates and shrinks the turbinates, probably more effectively than anything else that we could do to treat the turbinate. So it's helpful for patients if they breathe better after using Afrin. We generally know that the turbinates are the issue in terms of their breathing. However, repeated use of Afrin, generally over 3 days in a row, causes what we call rhinitis medicamentosum, which is a condition where there is a rebound congestion beyond the baseline congestion, which can only be remedied by using then more Afrin and more frequently. So that gets into a real dilemma for the patient.
It sounds like it becomes addictive.
It becomes a physical addiction in the sense that without the repeated Afrin, their breathing gets worse and worse.
So if that 3 days diagnostically improves their situation, you know it's turbinate inflammatory response, what would you say, where will you take the patient from there? What sort of decongestant or nasal spray would you give them for long-term use?
First line medical therapy for turbinate enlargement or reactivity certainly would be a nasal steroid spray, something like fluticasone. And that type of spray can be used on an ongoing basis every night as long as it's effective. Another first line medication that can be helpful would be like an antihistamine, which is now available in either oral form or in a nasal spray. And that can be useful also on an ongoing basis. It can be used every day as long as it's effective for the patient. We also have certainly decongestant pills like Sudafed, which can be used intermittently, although generally not recommended to be used every day because it will cause high blood pressure.
What would you suggest to a patient with regard to self-help remedies like nasal irrigation, neti pot, or any of these other saline rinses? How do they fit into the equation?
I think nasal saline is works very well for many patients, and it certainly is a safe way of cleansing out allergens or excessive mucus from the nose. So I certainly would encourage patients to try nasal saline as well, or alone, either with other medications or alone, to help them treat their congestion.
So is there a routine that you tell them, like every night you do this, or twice a day?
I usually let patients try to determine the regimen that they would use the saline themselves and tailor it to their individual needs. But certainly there's no reason that they can't use the saline either once a day or multiple times a day. It doesn't tend to cause problems.
Okay. Are there any other remedies that have seemed to help people? Like I had suggested a humidifier in the room. Are there certain menthol or kind of additives to these humidifiers, some vaporizers that can help people that way?
I think for patients with excessively dry nasal conditions, certainly a humidifier can be helpful, as can a saline jelly, which can be placed into the anterior part of the nose, into the front of the nose at night, and sometimes even a bit of emollient lubricant, such as Vaseline or Aquaphor, can be helpful for the patients who have chronic dryness or crusting in the nose.
Okay. Now, somebody comes to you with problems using their CPAP. Can you tell me what process you're going to take them through, and how you're going to decide whether or not it's doable? Because some of the nasal PAP interfaces seem like they spread the nose, they fit within the nostrils. Some may collapse the nose, they fit on the outside. There's a lot of pressure. So how do you enable people to breathe through their nose with a CPAP, especially when they say they're having difficulty?
Well, I like to look at a number of issues there, which would include the type of mask the patient is wearing, whether they find the mask to be comfortable, whether the mask has a proper fit, and whether they're able to breathe well with the mask on.
So, Dr. Roesler, why is it important that a dentist refers to an ENT? How is the ENT going to help the dentist with treating the patient?
Otolaryngologists can help the dentist with issues of nasal or oral obstruction, problems with the voice, lesions.
When would a dentist be worried about a lesion? Why wouldn't, in other words, what would be a cue that a dentist would go, oh my gosh, I've got to get you to an ENT? Because we don't look that far down behind the tongue.
Mm-hmm. I think some typical things would be any ulcerated mass in the mouth that would be visible should certainly be biopsied or evaluated. Any unusual growths. Any patient with an acute onset of hoarseness, any patient who would be spitting out blood, complaining of pain with swallowing, or any patient with inspiratory stridor.
So explain what that is.
That would be noisy breathing on inspiration.
Nasal breathing and sinus issues, are they related? In other words, somebody that has chronic sinusitis, is that related to drainage from the nose? Can you talk about that?
Okay. In terms of sinusitis, it comes in different forms. There can be acute sinusitis, which would be what we think of as when a cold turns into a more serious infection in the sinuses, results in pain or pressure sensation in the sinuses, which may be prolonged beyond the typical time period for a cold, may include foul discharge from the nose or into the back of the throat from the nose, green or yellow discharge. So that would fall into the acute sinusitis category. But many patients suffer from chronic sinusitis, which is a chronic inflammatory condition in the sinuses, which may also contribute to congestion in the nose, chronic excessive mucus in the nose, or may be associated with nasal polyposis, which is a condition where the lining of the nose becomes inflamed and actually gets filled with inflammatory fluid, what we call polyps, and these obstruct the nose.
Okay. What would a dentist look for if they were trying to figure out whether they should send a patient to an otolaryngologist? What are the things that they've got to cue into? So far, you told me sore throat, coughing up blood, difficulty swallowing. Give me some things that are telltale signs. We know if they can't breathe through their nose, we've got to get them to an ENT.
Well, that's right. And so we've talked about that. I think, of course, dentists spend a lot of time looking in the mouth. And so some common things that a dentist might identify, especially in terms of evaluating a patient for a dental sleep appliance, which could be easily identified, would include extremely enlarged tonsils which are either touching each other or nearly touching each other in the oropharynx, a long or thick soft palate or a very large uvula where the posterior pharyngeal wall is not easily identified. Large base of tongue can be contributory to obstructive sleep apnea. Those would be things that I'd look for.
How significant to you is a large tongue, like a macroglossia?
Well, macroglossia would be an extremely large tongue. For example, a tongue that might not even fit in the patient's mouth. But frequently we see patients with an otherwise normal oral cavity, but with a very large back of the tongue. And I think that's a very important factor in terms of the source of the obstruction in obstructive sleep apnea.
Can a dentist see easily whether somebody has a large base of the tongue?
I do think it takes a little bit of practice and a little bit of thought in terms of common looking for the source of obstruction in obstructive sleep apnea. But I do think that recognition of a large base of tongue is something that a dentist could do, absolutely.
So how can they tell that it's not positionally the tongue is pushed forwards, like a tongue thrust or an active tongue? How do they know that it's actually a large base of tongue problem?
Well, sometimes the tongue literally fills a good majority of the oral cavity, even when the patient is trying to enable the exam, a dentist or an ear, nose, and throat physician, in terms of the examining the oral cavity. So that would be kind of an obvious sign of the tongue being a source of trouble. Other airway red flags, would include the junction of the tongue and its position relative to the soft palate. So certainly there's a problem, a potential problem in patients where the tongue soft palate junction prohibits viewing the posterior pharyngeal wall within the oropharynx.
And that's a telltale sign that their tongue is up too high or they have too much mass.
It certainly is a telltale sign. I would say it's a red flag for consideration that the tongue might be an issue, along with an excessively long soft palate.
Okay. Now, I sometimes look in the throat behind the tongue, and I see uvula with little bumps on it, like little baby uvula off the uvula itself.
Mm-hmm.
What do you make of all that? Is that something that's a reaction to difficulty breathing? Is it a allergic response? Is it somebody messing with the uvula with, piercings and stuff like that?
I've never seen a pierced uvula,
okay,
but that doesn't mean that it doesn't happen.
Okay.
But typical things that one might see on a uvula would include just enlarged glands, which I don't think is a significant worrisome physical finding. Patients oftentimes will have a papilloma, pedunculated papilloma in the coming off the uvula or in the soft palate, which are generally benign lesions.
Do you get concerned about somebody having a long uvula? Does it mean something to you specifically?
No, I think that the uvula has to be considered totally in conjunction with the soft palate the length of the soft palate, the bulk of the soft palate, and then again the position of the soft palate relative to the base of tongue.
I've seen uvula that touch the epiglottis. They just seem ridiculously long. Is that something that's problematic because of that?
I think that's generally not a problem, actually, but it depends on the individual patient. And so, certainly in a patient with obstructive sleep apnea, if the uvula is touching the epiglottis, that would be a source of concern.
So do you do these reductions of the uvula, or do you do things to shrink the uvula?
Absolutely. There would be a typical sort of procedure that an otolaryngologist would perform. We do uvulectomy, and we also do wedge resection of the soft palate at the base, including uvulopalato-pharyngoplasty, and those would be traditional treatments for snoring. Let's take a look at a diagram here and talk about the anatomy inside the nose. So here we have a face here, and we've got the nose, we've got the nostrils, and then we're looking inside the nose in this depiction. We're going to see the inferior turbinates that come down, the inferior-most turbinate structure. We can see that on the side view here, that these are large structures in the nose. And just above that, we'll see the middle turbinate. We can also see in this diagram the sinuses, which are air-filled cavities extending off of the nasal passages. Here are the maxillary sinuses, the ethmoid sinuses, the frontal sinuses, and way in the back here we have the sphenoid sinus. What we're going to look at, or look for, in a brief nasal exam is how well does the patient breathe through their nostrils. Factors here include enlargement of the turbinates, the position of the septum, whether it's straight or crooked or deviated. We also might look at nasal valve collapse, which has to do with the external part of the nose where the junction of the septum and the upper lateral cartilages come together, kind of at the roof towards the front of the nose. We want to look and see whether that area is well supported or whether it collapses on inspiration. Other things that we can look for would include nasal polyps, which are inflammatory entities in the nose, benign, but can be very obstructive. And here's a depiction of a deviated septum, which may, if severe enough, completely occlude one side of the nose. So we've talked a little bit about the history that we want to get from a patient, and I think certainly the most important thing is just to start off by asking the patient, how well do you breathe through your nose? Do you have any trouble breathing through your nose during the day or during the night? Then we can get into a very simple exam of the nose without any kind of other tools, and we might just ask the patient, how well do you breathe through the individual sides of the nose? And without putting any pressure, pushing the nose one way or the other, I can use my thumb, occlude one side of the nose, and just ask you, can you breathe in? And we watch and listen and see how well air moves through the nose. And then we can do the other side. And I think you might feel that you are breathing a little better through the right side than the left, which could be the nasal cycle. That is, again, the cycle of breathing where one side of the nose will have a turbinate that's slightly more swollen than the other. Or that might be because your septum's deviated or your turbinate is enlarged on that side, or maybe you have some other source of obstruction.
What's the cycling?
The nasal cycle is a natural cycle by which the turbinate on one side or the other of the nose would be more swollen. So it may be swollen more on the right side or on the left side, the other side being more open, and it switches back and forth throughout the day, approximately, I think, every 2 hours. What I usually tell patients about that is that they shouldn't be aware of one side of the nose intermittently during the day becoming obstructed relating to the nasal cycle. They shouldn't be aware of the nasal cycle at all.
So if they are, it usually means that they have a problem with one side of their nose.
Exactly. And that can come up during the night too. Because if patients laying on one side, usually one of the sides of the nose will block up, and they may find that they can only sleep on one side or the other based on their nasal volume, nasal airway.
Okay.
So we've talked about a very basic part of a very basic nasal examination, but a very inexpensive tool that a dentist might find helpful in terms of taking a peek in the nose would be a nasal speculum. And so we'll go ahead and take a look in your nose using the nasal speculum, and we could use any light source, we could use any handheld light source. I'm going to go ahead and use my specialized light source, but again, dentists have all sorts of light sources at their disposal. So what I like to do is I've got my light on. I'm going to take the patient's head and just help them get comfortable so I can take a look in the nose. And then very gently, I'm going to insert the nasal speculum in one side, carefully expand the nares so that I can take a look inside, and I'm going to be looking at the septum and the inferior turbinate. And we've already determined that your inferior turbinate on this side is a little bit swollen just by our basic examination, and we can confirm that now. But otherwise that's pretty good. And we'll do that on the other side as well. And we, again, looking at the septum and the inferior turbinate. Now some patients, just by looking at the base view of the nose, we might get a sense for the septal obstruction. So sometimes the nose will have an appearance sort of like this, where this nostril might come down here, and then we're going to know that they're going to have trouble breathing on that side. So keep an eye out for that as well. So what we're going to do now is we're going to do a transnasal flexible endoscopic examination. I'm going to go ahead and numb up your nose and decongest you with a mixture of lidocaine and phenylephrine. Okay?
Okay.
All right. And you might want to hold that up. It may drip a little bit.
Okay.
And we're going to put a little spray in each side to make this nice and comfortable, and also to shrink the turbinates up so we can get a nice good look at the nose. And we'll do a little bit more on this side. Let's see which side gives us a easier passageway. Don't sniff in, just let that sit. We're going to get ready to go into the nose. This should be quite easy. You might feel a little pressure, a tickle sensation at some points, but it shouldn't be uncomfortable.
Okay.
Okay? So here we are, and we're just coming in through the left nostril. And we've got the septum on our left, and we've got the inferior turbinate right in front of us. And starting to shrink down, but we don't have a lot of room over here yet. So let's have a peek on the other side. I don't think we're going to get down that passageway very easily. Alright, so here we are on the right side of the nose. Now we have the septum on the right, inferior turbinate on the left. We've got a little bit of a septal spur here, kind of a mid-septal spur, extending superiorly. How are you doing, Michael?
Good.
And we're going to sneak underneath that along the inferior turbinate. So we're between the septum and inferior turbinate. And here's the middle turbinate up above us. And now we're heading towards the nasopharynx. Here we're in the nasopharynx. This is the eustachian tube opening. We're looking in the back of the nose where the adenoids would be present in a younger patient or in a patient who still has adenoid hypertrophy. How are you doing?
Good.
Now I'm going to have you extend your neck out towards me. Keep coming. Lean forward. Lean forward. Extend your whole torso forward. Keep coming. Keep coming. Chin up and out. And keep coming. And keep coming. This is going to make it more comfortable for you. You doing okay?
Mm-hmm.
All right. So here we are. Now we're going to look down. You doing all right?
Yeah.
We're looking down the soft palate. And this is in fact looking down the soft palate into the oropharynx and towards the larynx. So here we are on the back side of the soft palate, looking at the uvula, which is pretty normal in appearance. Here's the back of the tongue, the epiglottis, and I'm going to have you say E for us. Here's your vocal cords, and you're phonating. Breathe in through your nose, and the vocal cords are going to spread apart and let air through. Sometimes at what would be the top of the screen, looking down at the larynx, sometimes we can see signs of reflux there. And breathe through your nose, and the area of the posterior commissure of the larynx in your case looks quite normal, and your vocal cords look normal. We haven't discovered anything that we have to worry about. Here's the back of the tongue where we sometimes see some lingual tonsillar tissue, and it looks to me like you do not have your tonsils, or they're so small that you can't even see them. You want to comment on that?
I think I had them taken out when I was a young child.
Okay. All right, so now we're going to head out. Again, we'll review. Here's the nasopharynx, the eustachian tube opening, and we're going to come out between the septum and the inferior turbinate. We're on our way out. How are you doing?
Great. Yeah. It's an interesting sensation. So, Dr. Roesler, with young children, is there anything different about the exam or specific to young children that the dentist should know? What specific ages should they be sensitive to?
Well, I think that in kids we've got some simple questions that can come up that can help us to know if they might have a problem with obstruction. For one, snoring is never normal in a child. So snoring is a sign of obstruction more often than not in a child. In children, in a normal child who snores is a tip-off that an examination of the tonsils and adenoids ought to be undergone. So that would be a good reason to refer a child to an ear, nose, and throat physician. A child with a history of snoring or obstruction at night, parents always know.
And is this snoring once a week or snoring every night?
Yeah,
Or
consistent nightly snoring in a normal child would be a sign to be concerned that the tonsils or adenoids are obstructing the airway.
And is it typical for you to remove these, or is it something where you put them on medications?
So typically, again, in a child who doesn't have an infection or who's simply snoring and obstructing at night, removing the tonsils and adenoids, adenotonsillectomy, is a very straightforward cure for their type of obstruction. And literally, the moment the tonsils and adenoids are out, the patient starts breathing better, quiet, unobstructed breathing from then on.
It seems like there were many more tonsillectomies back in the 60s and 70s, and it lost favor. Can you talk to why that happened?
Well, we have a better set of guidelines based on clinical data to help us know when, based on a history of infections, for example, that we should remove the tonsils. So we tend not to remove the tonsils now if the patient has just a single episode of infection, or if they have a couple infections in a year or a couple year time period, which might have been enough indication to remove the tonsils and adenoids in the good old days. But now we wait. The criteria includes recurrent infections. For example, 7 documented infections in 1 year would be one of the clinical indications to consider removing the tonsils and adenoids. So we're more rigorous in trying to help patients keep their tonsils and adenoids, which are a non-essential but part of the immune system. But sometimes the tonsils will get particularly large or hypertrophic after a particularly bad infection, or sometimes it just occurs with a given infection kind of out of the blue. And certainly we always give the medication like an antibiotic, appropriate antibiotic, a chance to reduce the tonsils, but sometimes they remain hypertrophic nonetheless. It's important to assess, are those hypertrophic tonsils causing a problem, which, depending on the size, they may be.
Can you summarize the types of procedures that the otolaryngologist will do to help the patient to breathe better?
So let's start with the nose. Common operations that an otolaryngologist would perform to help a patient breathe better through the nose would include turbinate reduction, would include septoplasty or straightening the septum, also might include nasal valve reconstruction, that is adding support to the nasal roof to help with breathing. Those would be common operations that might be done in the nose. We also mentioned previously the issue of polyps, so nasal polypectomy, also sinus issues, so endoscopic sinus surgery. And then in the oral cavity or oropharynx, we have the removal of the tonsils or adenoids, often done together. We can remove the uvula, take a small wedge off the soft palate, uvulopalato-pharyngoplasty, and then some other procedures which might be helpful on an individual basis include reduction of the base of tongue or lingual tonsillectomy, as well as hyoid suspension or tongue suspension procedures.
Now the UPPP fell out of favor. It was done a lot more often.
That's right.
When was it, or why is it continuing to be done if it seemed to be very popular, found to be less than greatly effective, that it's even now considered?
Well, the uvulopalato-pharyngoplasty, that is removing the uvula, shortening the soft palate, has not had good clinical data to support its effectiveness in many patients with obstructive sleep apnea. So I think we have to take a hard look at what are the indications for that procedure. It certainly is an effective procedure for snoring, and I commonly do still recommend it for patients who have snoring but without obstructive sleep apnea. In a thin patient, without other anatomical issues like a large base of tongue or nasal obstruction, the uvulopalato-pharyngoplasty still can be considered, I think, for mild obstructive sleep apnea.
What are some of the most common pathologies that you see in the airway that the dentist should be aware of?
Deviated septum, or crooked septum, crookedness of the septum, enlargement of the turbinates, nasal polyps, which are often confused with the turbinates, but in fact have a more translucent, glistening appearance. In the oral cavity, we see in hypertrophic tonsils.
I've read about people having more problems with swallowing or food coming up through the nose, or issues associated with the missing uvula.
Mm-hmm.
Is the uvula important or not important?
I think the general consensus is that the uvula is not particularly important, but the soft palate does need to remain sufficiently long to form the valve with swallowing between the soft palate and the posterior pharyngeal wall. Otherwise, you can get into a situation called velopharyngeal reflux, which is a complicated way of saying that when you swallow, particularly liquid, it can reflux up through the back of the nose and come right out the front of the nose. And certainly we want to take extreme precaution not to have that occur in patients where we shorten the soft palate.
So what is the purpose of the uvula?
The purpose of the uvula seems to be to help guide mucus down the back of the nose comfortably into the throat, enabling that mucus to be swallowed. If without the uvula, the mucus simply goes down the side walls of the nasopharynx.
Now, postnasal drip is something that we hear from patients a lot in dentistry. It's associated with hydrogen sulfide producing bacteria and bad breath. And what do you deal? How do you deal with postnasal drip? Is this something that is just a nasal irrigation management issue?
So I think that saline nasal irrigation can be helpful for postnasal drip, because the postnasal drip can come from any source of inflammation in the nose. That could be inflammation in the sinuses, allergic inflammation, or non-allergic inflammation.
And is there anything specific the dentist should know about with the thyroid, doing a palpation of lymph nodes around the neck? Is there anything in their palpation exam that they should pay attention to?
Any asymmetric swelling in the neck, particularly if it's firm, would be cause for concern in further evaluation. Whether that's a mass in the salivary glands or an enlarged lymph node in the neck, that would be something I would watch out for.